So, hi, everybody. Thanks so much for joining us today. My name is Nicole Lamberson. I was trained as a physician assistant, and I volunteer doing outreach for the film Medicating Normal, and I host conversations like this one today. Our guest today is Dr. Jessica Taylor. She's the author of Why Women Are Blamed for Everything and the newly released Sunday Times Bestseller, Sexy But Psycho. She has a PhD in forensic psychology, and she is the director of VictimFocus. So, hi, Jessica. Thank you so much for coming on and chatting with us today.
Thank you for having me.
Yeah, sure. So I would hold up a copy of the book, but I had a PDF copy. But our moderator will put links to your books in the comments for anybody who's interested in purchasing a copy from Amazon. I guess just to start, so people can get to know you a bit more. What kind of work do you do at VictimFocus and as a forensic psychologist?
So I'm a chartered psychologist. My PhD is in forensic psychology. So I specialize in the psychology of victim blaming, of self-blame, specifically of women and girls who have been subjected to sexual violence, domestic violence, other forms of abuse. And one of my other specialist areas is trauma-informed approaches to working with women and girls who've been subjected to violence and abuse. And the way I see that is that they're totally interlinked, because a trauma-informed approach would not victim blame women and girls who have been subjected to male violence. And so I see those two things as, the same, really. In terms of what we do at VictimFocus, the work has just grown and grown over the last 6 years. So we're coming up to our 6th birthday. And it's a mixture of, training professionals, pieces of research, consultancy, going out and hosting panels, doing co-production work. We do all sorts of really interesting things. And the way that we work is that all of the funds that we get from, I don't know, so for example, training a big company or training a big organization about things like the psychology of victim blaming or trauma-informed approaches, we then reinvest in creating free research and modules and free e-learning for people who've been subjected to violence and abuse, free resources for those people who have been traumatized. So yeah, I mean, in the last couple of years, we've worked more and more and moved more and more towards exploring how to eradicate pathologization from professional practice. So like social workers, police officers, nurses, psychologists, counselors, that because the medical model is so dominant, most professionals and students are trained into the narrative that, people are mentally ill, people have mental disorders, and that the trauma is almost like a part of it, but they're biologically ill in some way, they're medically ill. Whereas obviously a trauma-informed approach is the other way around. It's that they're showing these behaviors and experiences and symptoms because of the trauma and the distress they've been subjected to in life. So we try to flip everything on its head, and it works very well. There's lots of professionals that really feel like they've always thought that's what it was, but they didn't have the confidence to challenge such a dominant narrative. So it's really interesting work.
Yeah, great. So I guess to start out, maybe it's good to sort of give us, you say this trauma-informed approach, but you talk in the book a lot about how, we're not clear about mental illness. We know very little, that things are like guesswork or oppression or myth. So what exactly are your feelings about, psychiatry and diagnoses and medication, just in summary?
That's big to try and summarize.
Hard. Yeah.
Okay, so I think psychiatry, I think psychiatry in similarly to psychology, like similarly to mental health, that as sort of an approach to trying to understand the human experience. Mm-hmm. I think we need to take a big step back and look at the origins of a lot of our belief systems. So for example, the belief of mental illness originated from the belief that people were insane and sick in the head and they were possessed by demons. And there's a very long, very well documented history between things like organized religion and psychology and psychiatry, you know, the belief that these people didn't behave in the way that society wanted them to behave, and therefore they were possessed. And obviously that didn't last very long, because people eventually moved towards science. And what's interesting is that it was the same groups of marginalized people that were then said, oh no, they're not possessed, that's ridiculous, what they actually are is mentally ill. And it was the same groups of people in history. So I personally don't think we've ever actually undone all of that work. So there's a lot of so-called mental disorders that were theorized and originated in that time period that we've still not unpicked, and we've not ever gone back and gone, but was that real? You know, did that exist? Like hysteria is a good example of that, you know, the belief that women are just biologically insane because of their uterus, and that as time went on, that turned to, you know, hysteria, then it turned to histrionic personality disorder, which was then moved to borderline personality disorder. You know, there's histories that sit underneath these disorders. The same with schizophrenia, was originally only diagnosed in Black people because it was seen as a Black disease. We've never moved really away from that. We've never undone that. We've never gone back and actually said, we now reject all of that. None of that science was accurate and we need to relook at it. We've sort of just, I don't know, we've like sort of glossed over it, moved on, glossed over it, moved on. And now you've got people that all say, you know, schizophrenia is genetic. What are you talking about? There's no evidence for that. We've, you know, if you look at the history of where schizophrenia came from, it was essentially dreamt up by white slave owners, people who were oppressing, harming, abusing, torturing Black communities, and then suggesting that they were more likely to be mentally ill than white people because they were Black. And, you know, still to this day in the US, for example, you know, you're much more likely to be diagnosed with schizophrenia if you're Black. That's still the same in the UK. You're much more likely to be sectioned if you're Black, much more likely to be heavily medicated if you're Black. And like, sometimes I feel like we're just not paying attention to the obvious patterns of oppression that I think they're like staring us in the face. So in terms of, you know, diagnosis, I don't really know what purpose it serves, because I often come across people that will say to me things like, oh, you know, I was diagnosed with depression 44 years ago. I've been on antidepressants for the whole time. I've never felt any better. I've never felt any different. You know, I'm going to be ill like this the rest of my life. And what's fascinating is that you can sometimes have like 10-minute conversations with people where you'll say, oh, what happened when you went on the medication? And they'll say something like, well, I was abused by my dad. And you sort of, and you think, is this not obvious that those two things are connected and that you're not ill? You didn't just suddenly get mentally ill, like, and you now need a pill every day. There was a root cause to why you felt traumatized and depressed, and as to why you weren't able to cope. So the labels for me they're just social constructs. They're just ways of describing something. So I don't really have any interest in them. I think that they're very powerful in terms of oppression and control, but I don't think they do anything for humanity.
Yeah. When you say power and control, in what ways do you think labels are, you know, used in that way, and how do they harm women particularly?
That was why I wrote Sexy But Psycho, because, you know, for all the years that I've worked directly with women and girls who have been sexually abused, or they've been raped, or they've been subjected to domestic abuse or human trafficking, it was so quick that somebody would suggest they had a personality disorder, or that they had PTSD, or they had bipolar or something like that. And even when I was much younger, before I'd done my PhD, that did not sit right with me at all. And I was sort of, even when I was much younger, I was questioning that and saying to people, but why do you think they have a personality disorder when we know they've been, for example, trafficked for the last 3 years, and now they're extremely scared and traumatized? Like, would it not make more sense to like almost allow them naturally to process all of that without suggesting there was an illness there? So in terms of, you know, this, how specific that is to women and girls, we know, and that's why I wrote Sexy But Psycho, that you've got this two-pronged approach where women and girls are sexualized, they're more likely to be abused, they're likely to be seen as sex objects, and then if and when they either step out of line, or they speak up, or they report abuse, or they, you know, go and report something to the police, every single part of them is assassinated, analyzed, why didn't you cry? Why do you cry too much? Why didn't you report? Why are you reporting now? Why didn't you stop them? Why didn't you do something about it? And then it's sort of like, well, why are you like I come across police officers that'll say things to me like, oh, we interviewed a woman the other day. She said she'd been raped. She was calm, totally articulate. She didn't cry once. So she's either a liar or she's mentally ill. And I've had to sit police officers down and say, that's not true. You can talk about a traumatic experience. You don't have to be sobbing. There's all this sort of stereotype that's built around how you should behave as a woman and a girl. It seeps into the narrative around whether you're mentally well, mentally ill, whether you're disordered, whether you're unstable, or whatever we want to call it, I guess.
A lot of the things you're saying are making me think about things that happened to me. I told you before we went live that I took psychiatric medications as a young 20-something. I'd started out with just work-related stress, and then I became so medicated, as often women are, because you have, adverse effects to the first drug. They say that that's your mental illness getting worse. Then you wind up on 6 meds. So I was like desperately ill on all of these medications. And in hindsight, like looking back at all of this and reading your book, I didn't realize, I think at the time, like how, I guess, just seeing the psychiatrist, how much risk I was putting myself at. In other words, like as a physician assistant, having a diagnosis, being a professional, that can be used against you to say that you're like unfit for practice. Or if I would have been well enough to get married and have children, which I wasn't, because the drugging was so bad and the withdrawal syndrome was so bad. I was sick for so long. It was my childbearing years. So I never thought about that when accepting the prescription. I'm 20-something years old and I might want to have children. It was never discussed with me. And I don't think they do it with lots of women. Like, hey, we're putting you on dangerous drugs that could hurt your fetus and you have to get off of them before you get pregnant. Only the withdrawal syndrome can take 5, 6, 7 years before you even felt healthy enough to be a mom again. But the big one is like hearing from women in our community who said, I just went for something benign, like me, like work stress or a divorce or something. And they used the diagnoses like in court, the husband or something, to say that the mom was so-called mentally unwell, to take children away from them. So, I mean, what kind of message would you say to women ahead of seeing a psychiatrist or accepting a psychiatric diagnosis or a medication when it comes to how risky it is for their credibility and everything else?
I think that is, again, like, I mean, there's 2 or 3 chapters in Sexy But Psycho just on that topic, on like family court, criminal court, the way that it could be used against you at work. And I think that honestly, in the current state and the way that medication diagnosis can be used to label you and then can be used to position you as unstable, unprofessional, non-credible, deceitful, manipulative, all sorts of things like that. My advice, unfortunately, would be, if you're worried about being framed like that, is to access services that will not take you down a diagnostic route. Because if you're struggling, you still need to access some service, or maybe you need to do self-help, like there's something, like if you're really struggling and you need to go talk to somebody else, then obviously that. But sometimes it's about picking who that is, and that can be very difficult because, for example, in lots of countries, you don't get to choose who you see. It's not as if you can say, well, I really need to see, I don't know, a trauma-informed psychologist. I'm not looking for a diagnosis. I'm just looking for support. I don't want medication. I want to process what's happening to me. You can sometimes be pushed down a route, which is like, well, if you're refusing the medication, no one can help you. Sort of like, if you're not going to accept this diagnosis, then maybe you're in denial. Maybe that's the mental illness, and it's like gaslighting. It's like sort of manipulative in that you can get stuck in a cycle. And the other one I think to bear in mind is, and I think which is a real catch-22, is when you're in family court, like what you talked about very briefly then, is that it's quite common for your ex or an abuser or whoever it is to ask for a psychological assessment of a woman and to suggest that she's not a good enough mom, or that she's dangerous, or that she's unstable. But from my experience of talking to, you know, like family court experts and also women who've been through that process, if you refuse the psychological assessment on the basis that you know they're going to pathologize you and you know they're going to position you as mentally ill, they can argue that you're refusing a psychological assessment, that you're denying something, or you're hiding something. And so in that situation, a few years ago, I asked a lawyer about this, and he said to me, our advice would always be accept the psychological assessment, because if you don't, you're going to look like you're hiding something. And I said to him, but if she does, she's very likely to be diagnosed after an hour and a half with somebody who she's never met, and turn up to court in a month and be told, oh, she's got emotionally unstable, personality disorder. That's what it is. And that's why she behaves like this. And that's why her ex should get custody of the children. And it's like, it's snap diagnosis that has a purpose. It's used for something. And so I think, if you've got the privilege and you've got the power to do it, my advice at the moment would be to avoid diagnosis at all costs and to go and seek help that is about you as a person and not focused on diagnosing you with a disorder that you're very likely to struggle to get removed from your file.
Yeah, good advice. So when I was reading your book, you talked about ACEs, which are, adverse childhood experiences. And I always thought when reading about them, that it sort of explained a lot. But you say that they can be problematic. So how so?
I think that the concept of childhood trauma is useful and developmental trauma is useful. But I think the construct and the almost like the theory of ACEs being almost a predictive measure of your outcomes, I think is toxic and is deterministic and reductionist. And I think that it's dangerous because, and that's without getting into the fact that ACEs is totally misused, and the original authors of the ACEs study, from 1998 have actually published in, like BMJ, and have asked for people to stop using their ACEs in a predictive way, to have said that it's been used as a diagnostic tool, which it never was. It was just a random set of 10 possible childhood experiences that might correlate on a societal level in epidemiological research. Could they possibly correlate with adverse health outcomes such as COPD, cancer, and actually even then there's a bit that's missing, which is that what they were really looking at was obesity, smoking and drinking. So the original ACEs study is not as simple as how people explain ACEs now. So you'll often hear people saying things like, if you have 4 or more ACEs, you are much more likely to get cancer later in life. That is not what that study said. That study was suggesting that there should be nationwide campaigns about the way that when we're traumatized, we're more likely to do things like smoke, drink, take drugs, that we have unhealthy lifestyles and whatever, because we're trying to cope. And that longer down the line, if you've smoked for 40, 50 years, of course your cancer risk is going to go up. We know that already. Same with drinking, right? So ACEs is misused, in my opinion, and in the opinion of several of its original authors, which is why they've asked people to retract. But I mean, some of the main things to consider about, I guess, the ACEs stuff is that, there can't possibly be 10 ACEs. I mean, think about all of the adverse childhood experiences that aren't even in there. There's nothing about bullying. There's nothing about racism. There's nothing about any form of oppression or homelessness, sofa surfing, or having to move from house to house. There's nothing about poverty in there. There's no systemic harm in there. Like it's so odd that people cling to ACEs. But you can kind of understand why, because I think that people want a numerical, quantifiable way of talking about their trauma and then to link it to their outcomes later in life.
Yeah, I think people are too, like, just desperately wanting to be heard and understood. And sometimes
Yeah,
in the same way that they embrace their, their diagnosis as pathology, it makes them feel like, oh, now I have something to explain to people so that I'm
yes.
understood. Like, I'm in this much pain. If I can tell you my label, maybe you'll get me or
Oh yeah,
understand.
absolutely. I
Yeah.
totally agree with that. I mean, if you consider that if your two options are explaining to someone that you're not coping right now because you were sexually abused for 6 years as a child, and then you met an abusive partner who you were with for a long time, and then he left, and then you lost your kids, and then or going, I've got anxiety.
Mhm.
There's a real difference there,
Yeah.
you know?
Yeah. I mean, there was one chapter where you talked about medical professionals who refuse to pathologize people. And I've met
Yeah,
some of them just doing these interviews. They say, like, if you want a diagnosis and drugs, I'm not the one for you because I'm
yeah,
not going to do that to you. That's not how I work.
yeah,
But then on the flip side of that, some women are not happy when the doctor tries to explain, they're not mentally ill, or let's not see your problems in light of an illness. Um,
yeah.
yeah, I thought that was
That
pretty.
makes I think that makes a lot of sense. And actually, I was talking to my wife about this the other day. Is that I had an experience of that myself when I was a teenager, and I was struggling with a lot of stuff, and I was trying to figure out what was wrong with me.
Yeah.
And so I convinced my GP at the time, I think I was 17 or something, that I wanted to see somebody and talk to them about how I was feeling. Because I mean, now looking back, I was essentially like having panic attacks, and I was struggling with sleep or struggling with eating. There was all sorts of things going on. And anyway, I got to go and see this woman. I think she was a psychologist, but I can't remember. She might have been a mental health nurse. Because obviously I was 17, and I think I wouldn't have understood probably at that point the difference between those anyway. But I remember sitting with her and telling her everything that had happened to me. And I remember telling her everything about how I was feeling. And at the end of it, even back then, she went, I don't think there's anything wrong with you, Jessica. I think you're struggling. And I was so mad at her. I was
Mhm.
like, but there has to be something that is wrong with me that you can help me with. And she was like, but there isn't anything. And you've just told me. And like she was like explaining to me, you've been through this and now you feel like this. You've been through this and now you feel like this. And I remember sitting there thinking, you don't get me. You're not listening to me. You don't understand me. You're not validating what I'm saying. And it's a weird experience because I think I blocked it out for a long period of time. And it was when I was writing Sexy But Psycho that I remembered this one appointment, because I remember storming out of this clinic and just never mentioning it ever again. I thought, that's it, I'm not talking to anybody about this. And it was like later, about 2 years later, I started getting like counseling and therapy and things like that when I was about 19. But I have a lot of empathy actually, because I remember feeling like that. I remember thinking there must be an explanation. I
Mhm.
must be different in some way. I must have a disorder. There must be something different about me. That is why I feel like this. But it's fascinating really that, I mean, that would have been what, 2007?
Mhm.
No, 2008, something like that maybe. So, yeah, 2008 it would have been. And if you think like that was a while ago, she must have been quite a one-off at that time as a professional herself, because she could have just gone, yeah, it's just depression, anxiety, borderline, whatever. She could have just medicated me and let me get on with it.
Yeah. Yeah. True. You found like a rare gem and you didn't even know it at the
No, I
time.
didn't. I was so mad. I was so angry.
Well, and I don't know how much in the UK. I mean, I know you guys don't have direct to consumer advertising with medications, but in the United
No,
States, we do,
yeah, you do.
but
Yeah,
even still, I think over there, the societal type expectation is that if you have a diagnosis, then you can be medicated or they can give you something, So I can understand why people want, to be diagnosed, because then it's like, oh, well, there's a solution then, there's medication, there's
yeah.
something you can do for me.
I think some of that though is because and I talked about this in Sexy But Psycho, that and other authors have talked about this as well, is that we've gone down this route where we've created, like, we've conflated physical and mental health. So
Mhm.
what you'll get people doing, thinking that they're being really clever, is saying things like, um I don't know, they'll say something like, well, my antidepressants are the same as insulin. If I'm diabetic, and if I don't take the insulin, then this will happen to me. If I don't take my antidepressants, this will happen to me. And they'll claim that insulin is a chemical imbalance and that depression is caused by chemical imbalance. And that is a false equivalency. That is not true. And that is not what depression is. But because of that, and because of the highly, I would say, like, seductive and influential sort of narrative that you can be told you have an illness and then you take the medication and the medication will solve it. And then if you keep taking that every day, you are going to feel much better, which would be the equivalent of things like an antibiotic or taking insulin, you know, to help you as a diabetic or something else. You know, it means that people have wholesale bought into, because they have been sold it every single day, that if you have, for example, PTSD or anxiety or depression, or you've been told you've got a personality disorder, that you need to take the medication every day because it's an illness that can be medicated. And I think that's where I start to get really irritated, because there isn't any evidence for that. And we know full well there's no evidence for that. You know, thousands of professionals know there's no evidence for that. But equally, there are thousands and thousands more, you know, that genuinely do believe that there's, you know, things like evidence for a chemical imbalance in the brain, or that there's evidence that I don't know, that people need to take so-called antipsychotics, which don't exist. That's just a marketing term. You know, people talk about antidepressants as if that's not a marketing term. You know, it's incredible how much marketing has been done. And I think you say that in the US, yes, you do have like direct to consumer marketing, but to be honest with you, I think a lot of it in the UK has just been done covertly, because we've had the same effect.
Oh, yeah. Yeah, exactly. Let's shift gears a little bit to, you know, like writing off real legitimate complaints. You know, we hear all the time women go into the doctor and they have cancer, or they have some thyroid disorder or something that's never checked for, simply by way of, you know, oh, well, this is in your head. I think all women could say they've experienced some kind of being written off as something is in your head. But when it's done by other women, that's the part that really gets me. So why do you think there are even women doctors who have this type of, oh, it's in your head, and ingrained type of thinking?
I think the way that I usually explain that is that, you know, if we're all growing up in a patriarchy and we are all surrounded by misogyny and sexism, women aren't immune to that. You know, women end up misogynists. Women end up believing that other women are inferior, that they are attention seekers, that they're unstable, that they're highly emotional. And so that also includes professionals, you know, that you can very often come across female counselors, therapists, psychiatrists, psychologists that are extremely harmful to women and will tell them it's all in their head. Or, you know, you might go to a female GP and you know, there again with the misogyny, you sort of assume that if you as a woman go and see a female professional, that they're going to have higher empathy for you, that they're going to listen to you, they're going to support you, and they are going to believe you. But that is an assumption also based on gender role stereotypes, that the woman is more nurturing, she'll care for you because she's a woman, whereas if you went to see a man, he would have less empathy, he can't relate to you because he's a man, right? But because even though some of that might be true, that doesn't make the opposite true, which is that therefore a woman will relate to you, she'll totally believe you, she'll validate you, she'll support you, she'll have high empathy, low blaming, and that's not the case. Research has never shown that to be the case. And, you know, as the years have gone on, we found more and more evidence actually that female professionals will, you know, victim blame and have lower levels of empathy at the same level as what men would. So, you know, it's more of it's an assumption we make more than anything that women would be better at that. But I think, yeah, you know, even female professionals are likely to have been influenced by toxic, misogynistic values about women's health and about their own health. Because in the same way that you get women saying things like about like domestic violence, they might say things like, well, if my partner ever hit me, I just leave. And you think, yeah, okay. That's not how that works. But, you know, like women will say that to other women and they'll sort of say, well, it's your fault you stayed in the relationship. And I think you see that same thing in medicine, that like a woman will say something like, well, if I was in that much pain, I wouldn't be sat there. Or, you know, if that was really happening, I would have X, Y, Z. So, you know, they're doing it to other women. They're often doing it to themselves, or somebody did it to them and then they've taken it on and projected it on somebody else. So it's sad really, but I think that it's quite dangerous for women to go along or want to believe in that purely based on sex they'll get a different service. I actually think it needs to be based on, you know, their ideology and like their training and like their ethos and their theories, because you could get a woman, for example, that was highly pro psychiatry, pro diagnosis, pro medication, but you could go see a guy who didn't believe in any of that and sat with you and said, well, I've listened to all these things. You're telling me you've lost your job. You're telling me you're going through a divorce. You're telling me that, I don't know, one of your kids is very unwell. And I can hear that. And I can hear you telling me you're really distressed. I don't think that's a disorder. And that's not sex-based, is it?
Yeah, that's a really good take home message. You know, don't maybe select your providers based on gender and sex. Look at, you know, how they treat you and what they believe, and interview them. I always advocate now, after what happened
Yeah.
to me, for, you know, like being your own best health advocate and firing doctors that don't listen or don't treat you the way that you want to be treated when you go in there, you know?
I think that's such good advice. I really love that. And you started to say like to interview people, and that's something that I feel really strongly about as well. And it's something I do personally, that if I come across a professional, either in my working life or in my personal life, say, for example, I went to the doctor or I had to go to see a consultant or someone like that, or if I was looking for a therapist or somebody, I will often question them. And I've got a set of questions. I put them on my Instagram and I put them on my Facebook and stuff. It's like 5 questions to ask a new like therapist or to ask your professional to figure out if they really are trauma informed. Because the thing is about being anti-pathology and trauma informed, is because it's quite sort of trendy and it's a bit buzzwordy. So a lot of professionals that are saying that they are that thing, but they can't back it up. So what you tend to find is their knowledge is so superficial that if you ask them the right questions, they trip up within a couple of sentences. So, you know, you might say to them things like, oh, you know, you could just lie to them and say, oh, I think I've got this. And, you know, do you support like medication in this particular disorder? And like, what do you think of ECT? And like, are you supportive of EMDR? Or like, you could ask them some questions and their answers will give it away very quickly. Because somebody who is anti-pathology and trauma informed will quickly move into the narrative of, I don't particularly believe in that disorder. I think that it's usually trauma. And in terms of the treatment or in terms of what's best for you, I will be guided by you, and let's look at what we think you need at this point in your life. Like if their answer isn't like that, there's another ideology or theory or sort of approach going on.
Yeah. Just to clear something up quickly, because this is something that comes up all the time when we have these conversations. And I hear you saying, I don't particularly believe in that disorder. What you're not saying that people aren't suffering, right?
Oh yeah, no, but like human suffering is universal, but I guess the way when I say that, what I mean is that I do not believe it is abnormal, and I do not believe it is a disorder of the mind. I believe that, so for example, someone might say, yeah, but you know, I have nightmares every night and I can't sleep and I'm not eating and, you know, I'm having panic attacks, I have palpitations and I get headaches and I hear voices. But, I'm not, I think all of those things are happening, but do I think they constitute a mental disorder or a personality disorder that is innate in you, caused by some sort of chemical imbalance? No, I absolutely do not believe that. I believe that it is a natural, normal response to something that is seriously distressing you or has done previously in your life and is not resolved or is still traumatizing you. So I just don't, if you look at the word disorder, it's arguing that it's an abnormal, irrational response, which I don't think it is.
Yeah. Yeah. Makes sense. So you talk about grooming in the book, and when I heard that word or had understanding of it, it was always about, child sexual abuse, the older male
Yeah.
perpetrator grooms the young child victim. But you relate grooming to psychiatry as well. How can psychiatric victims or patients be victims of grooming?
That's because I don't. So, okay, the current usage of that word grooming is generally associated purely to sexual grooming.
Mhm.
And so people see it as like it must be a sexual offense, it's grooming, right? But in my view, having worked with thousands of people who have been groomed, children, men, women, you can, and also worked with academic researchers that were looking at grooming, you can be groomed into an ideology, you could be groomed into extremism, you could be groomed into radicalization, you could be groomed into being trafficked, you could be groomed in your relationships, you could be groomed in abuse, your parents could groom you, your like swimming teacher could groom you, like,
Mhm.
and so I also think grooming happens on a societal stage. So you can be groomed by the media to believe something that you didn't previously believe. You can be groomed into changing your behavior. You can be groomed into changing your ideology or your politics. So I've written an article about this before where I've sort of said grooming is probably one of the most common human behaviors. We just don't like to talk about it in that way. We don't use that language because it makes us uncomfortable.
Yeah.
But when you look at the dynamics of grooming and the way that it works, the tactics and the outcomes, it's very successful and it happens all the time. You can walk into a shop, for example, and somebody could try and sell you a product that 3 minutes ago you didn't know existed, and by the end of that conversation you're convinced you need that product. How is that? That's grooming. That's manipulation. It's persuasion. And that's because grooming in itself is just a collection of coercive behaviors, and they range from positive sort of tactics, things like gift giving, showering you with compliments, love bombing, telling you you're amazing, spending lots of time with you. But grooming can also be all the way down the other end, which is threats, violations, abuse, lying about you, manipulating you, blackmailing you. But for most people, any form of grooming is actually a mixture between those things. Like it's not really one end of the scale or the other. So in terms of like psychiatry, I think that socially, and I think globally, we have been groomed into the narrative that people who think differently, behave differently, look differently, experience the world differently must have a mental illness of some kind, and that it's some sort of disorder, it's some sort of difference that needs to be addressed. Whereas actually, I think if we looked at it scientifically and looked at it through things like evolutionary psychology, we should expect people, especially in a population this big, to be totally different from each other. Like we should be able to put, for example, 100 people in a room and get them to look at, I don't know, the same 10 seconds of imagery and to have totally different reactions to it. For some of them to have zoned out, for some of them to see something different in it than someone else, for some people to understand it and not understand it, for some people to be bored out of their brains and for some people to think it was brilliant. Like why that variation surely is natural.
Yeah. That makes a lot of sense. I'm curious if you find it strange that people who care about social justice are not more like inclusive of people harmed by psychiatry and their activism. It seems like a lot of people who care about social justice think that like campaigning for more psychiatric services puts them on the right side of history, but they're missing this piece of like this significant portion of people harmed by psychiatry. Do you see that in your work?
I do. Yeah, I do see that. And that's such a fascinating question because I mean, I see that play out on social media. There's lots of activists that have been harmed by things like benzodiazepines, by ECT, by there's the akathisia community. I don't know if I've just said that right. I'd never pronounce that word right. And there's people that are trying to taper off their medication, having severe withdrawal symptoms, or I mean, I've worked with teenage girls who have been trafficked, who were put on very heavy sedatives, antipsychotics, so anti-seizure drugs, and it significantly impacted them cognitively. You know, they slept a lot, they missed school, they were not able to read anymore, they were not able to count. Like, it was really impacting them. And when you sort of bring that up and say the damage these drugs are doing to this teenage girl, you know, what are we going to do? Like, she needs to come off them safely, we need to protect her. And people sort of say, yeah, but she's a lot calmer on the drugs, and she's a lot, you know, so there isn't really a motivation to get her off them. And then, as you'll know, coming off this stuff, lots of people are not told about withdrawal impacts, they're not told about side effects. And as you very rightly said right at the beginning, when you try and talk about your side effects, you can often be told that's actually part of your mental illness. So the side effect doesn't exist, it's actually you. But when people speak out and they say, I don't know, I've come off 15 years of benzos and I've now got all of these health issues and I'm attempting to, you know, get healthy again, and I think I should have been warned about that. I think really this is down to like informed consent and patient information and things like that, which isn't happening. But there is really, isn't there? There's like a hatred. I think there's a hatred towards people who've been harmed by psychiatric drugs and by psychiatric treatment. I would extend that also to include like harmed by therapists, harmed by psychologists, harmed by, like, you know, counselors, because there's also a lot of harm that can happen there. But if we talked about medication, I don't know. I really wonder if it's because it would unpick so much to actually acknowledge that these victims exist, you know, that there is this huge community of people. And then I also wonder if it's because if they've already been positioned as mentally ill and therefore non-credible, why believe their accounts of their side effects and withdrawal impacts, right?
Yeah. True. You're just a mentally ill person. You probably need your meds. And so your experience is automatically not valid. But I think it also comes down to maybe so many people are medicated that when you start, I don't know,
It
I can't
triggers
figure out.
people, right?
Yeah. Well, because I think about like when we buy something on Amazon, right? Like nobody's mad at us for reading the reviews first. Like you wouldn't think I was nuts for not buying like a 1-star thing that everybody said was a piece of junk. But when you take psychiatric medications and you come and you say like, look, I'm a consumer, I tried this stuff, it damaged me badly. And I'm in this group of thousands and thousands of other people who are saying the same thing. And then people attack you and get angry at you or call you a Scientologist or try to silence your message. It's like, I don't understand where it comes from. Yeah.
I think some of it is, I mean, so we know in the UK, 1 in 5 adults are currently taking an antidepressant or an antipsychotic, and that's gone up again in the last sort of 12 months or so. So we're at the highest proportion of that we've ever seen. And so it's very likely that your family members or your friends or, you know, like 1 in 5 around you in your workplace are taking these drugs. So it's very personal to people when you start to say, you know what, I don't think I should have been given these drugs. I think they harm me significantly. And I think people should have been warned. And I think there should be informed consent. I think you should know from the outset what the risks are. I think there are some people that genuinely believe that those drugs are actually saving their life. You know, there's like, for example, people get told that they're taking antipsychotics and that it's like curing their psychosis, but those drugs don't have that capability. That, you know, most antipsychotics are anti-seizure drugs. They're used in epilepsy, and they're not specific to a psychological change around psychosis. They're often very heavy sedatives. So, you know, yes, you might sleep a lot. Yes, you might feel suddenly extremely drowsy and calm. It's not going to change the thoughts going around your head that you're not good enough or that you don't want to remember the fact that you were sexually abused or whatever it was that's gone on. I think the conversation around it is almost like cloak and dagger, like you're not supposed to say the truth. And then the other thing about, like you said about Scientology, last year somebody put a load of posts up saying I was a Scientologist, and I know nothing about Scientology whatsoever, so I had to like Google why the two things were connected, because I was like, what is this? I didn't know what it meant. And then I've had, like, for talking about this stuff, which I think is just a normal part of science, I think that if we were going to talk about frank, open, critical scientific debate, this conversation should just be a normal part of conversation. You know, this should not alarm anybody. This should be, let's talk about this other perspective and what the evidence is suggesting. from this group of people because it's fascinating, but it's actually seen as threatening, not fascinating at all. And the other one is like QAnon. Like people say that all the time, and I had to Google why those things are connected because I didn't know. But do you know what it reminds me of? It's just the way that if you say anything remotely critical of anything, one of the most powerful things, well, two most powerful things will happen to you. The first is that people will suggest you're mentally ill and unstable. And the second is that they'll suggest you're a conspiracy theorist.
Mhm.
And that will happen if you're talking about veganism or if you're talking about this. It doesn't really matter. It's, you know, if you're talking about anything that's critical or in any way sort of threatening to the status quo, those are the two main things that will happen.
Yeah. Yeah. So true. So I'm conscious of the time. We have a couple minutes left, and I wanted to bring up LGBTQ issues and psychiatry. Obviously when I was seeing my psychiatrist, I wasn't questioning of psychiatry at all. I was fully bought into the medical model and that kind of thing. But I found out later that she was part of the LGBTQ community, and then read, the history of psychiatry. And it wasn't really that long ago, was it, that psychiatry pathologized people's sexual preference as a mental illness, correct?
Yeah,
and where
absolutely.
do things stand currently with psychiatry and that?
So what we know from the history and like what I wrote about in Sexy But Psycho is that generally speaking, it was gay men that got some of the worst treatment from psychiatry because of, I guess, because mainly because of misogyny, because lesbians weren't even really seen as a thing. So, for example, a lot of the documents and a lot of the guidance for doctors about treating homosexual patients were all about men, because homosexuality in women was just seen as like ridiculous. Like it wasn't a thing, that women weren't doing this anyway. It was the evil, sinful gay men that were doing it. So a lot of it was aimed at men. And so a lot of the most deadly and abusive treatments, everything from like exposure type therapies through to like forcing them to be in ice cold showers for like weeks on end, or making them watch gay imagery or gay porn, or what would have been close to it, like not nowadays, but like sort of back then, like images of men kissing or having sex, and then like electroshocking them, or one of the studies from the UK was that like they made gay guys like look at images of other gay guys, and then they like smeared them with like feces and stuff like that, and they were using like behaviorism. They were trying to cause like associations between like looking at the imagery and like being like sick and disgusting. Whereas with lesbian women, for example, like I said, they were just seen as just like almost like just didn't even exist. And so men, I think, were more likely to be seen as evil, dangerous, nasty if they were gay, whereas women in history and psychiatry were just seen as like confused, unstable, like mentally ill. And so, like, for example, with lesbians, a lot of the treatment was about getting them to have sex with men, getting them to marry a man, getting them to get pregnant by a man, convincing them that it was some sort of phase, it was a fad, it was, it was ridiculous. And so there isn't as many studies about the way lesbians were abused in psychiatry, just because they weren't even taken seriously at all. But of what was there, it's pretty bad. It's like similar sort of tactics, but I think more down the route of them just being just absolutely crazy, like mentally ill.
Yeah.
And so in terms of like where we are now, I think that there's still evidence coming out that you're much more likely to be diagnosed with borderline personality disorder if you're bisexual or lesbian. You're much more likely to diagnosed borderline personality disorder if you're female. You're much more likely to be diagnosed with a personality disorder if you're questioning like your sexuality or your identity or something like that. You're much more likely to be told that you're mentally ill if that's the case. And then there was a study that I read recently, I think I cited it in the book actually as well, that said that, of an analysis of women who were on wards for borderline personality disorder, the vast majority of them were lesbian or bisexual. And so historically, the criteria for the borderline personality disorder diagnosis included confusion around sexuality or changing sexual identity or something along those lines. It doesn't surprise me at all that that's still there. And I still think that we have a tendency still to suggest that gay, bisexual, lesbian, trans, non-binary people are mentally ill. And it's amazing, really, that sometimes you watch really intelligent people that seem to get it on one subject, and then you sort of say, yeah, I know, look, it's happening here as well, and then they go, no, they're mentally ill. And you're like, what? How do you understand it in this argument, for example, but not in this one? It's the same form of oppression, right?
Yeah. Well, if you have your finger on the pulse, though, of that community, the LGBTQ community, like, do you think there's just been enough time passed between those abuses and now that members of that community would still turn back to psychiatry and ask for help and diagnoses, or do they just not know the history? Or
I think it's a mixture. So people don't know the history. They don't know that they're more likely to be diagnosed. And also because of identity politics, individualism, and things like that, they're actually convinced that getting the diagnosis will help them in some way, or that it will almost like validate how they're feeling about things. And that it means that sometimes I think it's that they just don't know the connections between homophobia, psychiatry, homophobia, psychology, things like that. But I do think that it has been marketed, especially to our younger generations that are now sort of growing up and maybe like under 30, and they're, lesbian, gay, bi, trans, non-binary, queer, whatever, like however they identify, right? Or whatever their sexuality is. That I think that they have been almost like validated that mental illness and mental disorder is not a thing, and it's just mental health, and that everybody struggles with their mental health. And I think they're almost like a captured generation that don't even question any of the narratives around mental health whatsoever.
Yeah. All right. So last question. I mean, I've said this all along, there's power in numbers, and there's a lot of women in the world, and there's men who support us too. So what do you think, like, what is your take home message, or what do you want people to know as women, what we can do to start shifting things in a better direction?
I think, oh God, there's so many. In this topic, or like just generally?
Yeah, I mean, I think we'll stick to this topic just to keep it more simple. Yeah.
So one of the things that changed my life was to watch your language, and to really like pick apart some of the things you say. So if you want to start really questioning the way you use pathologization to the people around you and to yourself, is to watch the way you talk about people. So for example, it's very common to say things like, yeah, well, she's just crazy, or like, yeah, well, I've had a mental day, or like, yeah, well, they went mental. Like, like the constant language of like, yeah, well, they're just a psycho. Like, oh, they're such a narcissist, they're such a sociopath. And it's like, do you hear yourself? Like you are, and so years ago, I just chose to just stop. And I just thought, every single time that comes into my mind, I'm just gonna use a different word. I'm just gonna pick something else, and I'm gonna deliberately say the word that I actually mean. So if for example, instead of me coming and going, oh, I've had a mental day, I've over the years I've trained myself to be like, I've had a horrible day and I feel exhausted. It wasn't mental. It was, you know what I mean? Because that comes from saying it's mentally ill. And so like changing your language is like, you also look at the way you talk to yourself. You're not going crazy, you're not mental, you're not unstable, you're not a bit OCD, you're not, like watch how you're talking to yourself, like in terms of pathology, and then watch how you're doing it to other people, because that's like your first little change, I think.
Yeah. And also we see it all the time in people claiming diagnosis where they say like my anxiety versus just feeling anxious,
That's great. That is such a great point, because you're absolutely right, is that when you talk about it as like, I've got anxiety or my anxiety is playing up, rather than, again, using the language to correctly describe how you're feeling. So I am feeling scared. I am feeling anxious right now. I am nervous. It stops you from almost becoming the whatever it is you think it is, a diagnosis, a label, an illness, whatever, and actually goes back to describing your normal human emotions.
Mm-hmm. Yeah. Well, Jessica, it's been fascinating talking to you. I could probably sit here for another couple of hours. Your book was just incredible to read. And I think anybody interested in learning more about like the history of all of this, I mean, you go into all of that in much, much greater detail. So like I said, we'll put a link to your book for anybody who wants to read it, and your previous book too, which is called Why Women Are Blamed for Everything. Did I get that right?
Yeah. Yeah.
So if people want to follow you or read more of your work or that kind of thing, where's the best place for them to go?
I'm on most social media platforms under @Dr. Jess Taylor. So most of the handles are the same. So you can search them, and that includes like TikTok and stuff, and Facebook and Twitter and Instagram and LinkedIn and stuff. But also, you know, if you want to download free resources, if any of you are sort of listening, thinking about some of the things we've talked about, especially about medical misogyny and about pathologization, on the website victimfocus.org.uk, we have tons of free resources that you can just download, take to your doctor, take it to your blood test, take it to your, you know, cervical smear test. And so that if you have been traumatized and you know those things trigger you and you know that you need some advocacy, all of the free resources are there.
Okay, awesome. Thank you so much. Any closing thoughts before we wrap it up?
No, I just want to say thank you. I really appreciate it, and I hope that it's been useful and interesting. It's always good to, like, I guess, talk to people that have got some insight and ask interesting questions. So thank you.
Yeah, sure. All right, everybody. Thank you so much for joining us for this live discussion. If you haven't seen our film Medicating Normal yet, you can go to medicatingnormal.com/watch for the many ways you can view it. The film's also on DVD right now if you're in the United States and Puerto Rico. As always, check our events tab on our Facebook page for more scheduled upcoming interviews like this one. Thanks so much again, Dr. Taylor, for joining us, and thanks everybody for tuning in. Bye, everybody.
Bye.